This is Dr. Bernstein with your June 2019 teleseminar. Before we begin, I want to give you the usual warning. First of all, I will not answer questions more than 2 or 3 sentences long. I will not answer a question that is really multiple questions. I might break it down to one question. Furthermore, my replies will be generic replies that may not apply to your particular situation, but will be of interest to the other listeners. So if I seem to have solved your problem, don't count on it. It may not be correct because I haven't done a physical exam on you. I haven't gotten your complete history, your family history, and so on. I don't know all the medications you're taking, and it's impossible for you to give me all that information in a few lines of text. So these are just generic answers to questions. We have 2 special subjects today. The first special subject relates to the relatively high frequency of supposed cures for diabetes, sometimes for type 1, sometimes for type 2, sometimes for latent autoimmune diabetes, and all of these so far have been false, I should say phony claims. There are ways of increasing your suspicion about a claim. One way is to take a look at the names of the principal investigators in the report and see if they have made other claims for cures in the past, especially if they were a different mechanism. That you might have the same individual claiming one mechanism for a cure this month, and maybe 3 years ago he had another cure, and before that he may have had another cure. So beware of that. Beware of any authors who are selling something at the same time, a supplement, a treatment, and so on, and claiming a cure. There should be a very high level of suspicion. I have yet to find a cure for any form of diabetes. There are claims about pre-diabetes. Well, if someone has a very slightly elevated hemoglobin A1C, that is, if it's, let's say, 5.2 or 5.3%, and he's obese, and you get his weight way down to the normal range, and his A1C comes out under 5, you may have cured his pre-diabetes, maybe. But he's still susceptible to diabetes because he had slightly elevated A1Cs in the past. Our second special subject was prompted by a question from one of our listeners, and I'll read it to you. Have you considered polling your patients to see if any have successfully switched to generic metformin from glucophage? There are at least 24 generic manufacturers. And this reader then sends me to a site operated by the National Institutes of Health in the USA, where they have looked at patients in Taiwan where there are several generic metformins, and they've tried to see how many people stopped taking the new drug when they switched. It's a very difficult study, and it's hard to tell any results, and you don't really know why the people switched. Were they getting side effects, adverse effects, and so on? Nevertheless, I have observed my patients who switched to generic metformin from glucophage, and we have a variety of results. Some people, for example, may have been getting diarrhea on glucophage and are no longer getting it on the generic version. Some people were getting normal blood sugars with glucophage plus whatever else I had them doing, usually diet, maybe diet plus exercise, maybe diet plus exercise plus a little bit of insulin. But they switched from glucophage to a generic and the blood sugars went up. Some people had constipation on glucophage, and the constipation went away when they switched to a generic. What I've found is that the generics are not all the same. Why they differ from one another, I do not know. Are some of them the same? Out of 23 different manufacturers, are some of them very similar, some of them different? I can't tell. What I do know is that there is variation. There's variation in adverse effects, there's variation in efficacy, and I do not have any documentation saying that this particular brand is better than another brand, or that a particular brand has fewer adverse effects than another brand. It's unfortunate that we have so little information. It would be nice if the original formulation for glucophage came back. At least we know that it has very good potency. We also know that it has potential adverse effects for some people. One potential adverse effect that could relate to any of these versions is that for some people, the vitamin B12 receptors in the intestines may become blocked. And we can test for this by measuring a combination of serum B12, serum methylmalonic acid, which should not be elevated unless you have a B12 deficiency, and serum homocysteine, which might be elevated if you have a B12 deficiency. So anyone getting any form of metformin, every 6 months or so, I'll recheck those tests. Now back to the first question today. I'm reading your book. I saw your recommendation to supplement with vitamin D3. Didn't see a recommended daily dose. Any help? Yes, if I recommended it in the book, I probably recommended that the dosage be designed to put your serum level in the normal range. And I prefer near the higher end of normal because I suspect that the so-called normal range, which is 20 to 100 nanograms per ml, may be on the low side. So I try to keep my own D3 level at about 100 nanograms per deciliter, or just under 100. There has been speculation as to could there be adverse effects by having too high a level. That's speculation. My interest in vitamin D supplementation came from a study I saw on roof repairmen on the Isle of Sicilia, where 20 minutes of exposure to the sun without a shirt brought about 21,000 IU, international units, increment in D3 levels in their serum. And I figured since our ancestors grew up around the equator and probably didn't wear shirts, they were probably getting huge amounts of vitamin D3 every day. And perhaps those of us who don't get sunlight should take substantial supplementation. Anyway, it's a trial and error thing where you measure your blood levels. You probably give it 3 to 6 months at a certain dose. You might start with 100 IU dose, or some people start with 500 IU. I find that I cannot get my blood level up to about 80 or so without getting 10,000 IU twice daily. It's a huge dose, but my blood levels don't reflect it. Okay, next question. I'm healthy except for Parkinson's disease. My hemoglobin A1C is 5.4. My estimated average glucose based upon the A1C is 108. Now, right away, I want to say something here. The ADA claims for what blood sugar, at what average blood sugar corresponds to what hemoglobin A1C, are incorrect. They tend to run on the low side. They're based upon a study that used a blood glucose meter that tended to read low. So I find a 5.4 is more like 116. The ADA, according to this person, claims 108. I have gut issues, bloating, early satiety, slow emptying, and also poor circulation in hands and feet. So I have another comment here. The person doesn't say whether the circulation was measured scientifically. And I do know that about 80% of my new patients, when I see a new person and do a physical exam, I find that they have Raynaud's phenomenon. And when they give me a medical history, they tell me that if they're out in the cold and they come back into the house, their hands and or feet remain cold for sometimes several hours. Or when they go to bed at night, their feet are cold. That's usually Raynaud's phenomenon. It's an autoimmune disorder that's frequently inherited along with diabetes and other autoimmune disorders like psoriasis. So this poor circulation may not be impaired circulation. It may merely be Raynaud's phenomenon. The person next says, I was tested and do not have gastroparesis. Now, the only way I know of to test for gastroparesis is the RR interval study that that is discussed and even filmed on one of my videos. So it's unlikely that this person was tested with an RR study. They probably did a gastric emptying study, which is very erratic because gastroparesis itself is very erratic. You sometimes can demonstrate it on a gastric emptying study, and usually 2/3 of the time you miss it. In reading about your work, I'm tempted to try your diet. I had gestational diabetes. My mother and father had diabetes. So I guess the person is wondering whether she should follow a low carbohydrate diet. Well, I would think that if her A1C is over 5, it's 5.4, if she has a family history of diabetes, she should do what my children are doing. They're following low carbohydrate diets, just like mine. So it's certainly not going to do any harm. Is there anything that we could or should do to prevent a catch-22 situation between two drugs, such as Synthroid and metformin? For example, I just read on drugs.com that levothyroxine, which is T4, the hormone in Synthroid, may interfere with blood glucose control and reduce the effectiveness of metformin. Well, first of all, I know of no cross reaction between T4 and metformin. But historically, there have been observations that T3, liothyronine, can increase blood sugar levels. I've been taking liothyronine since I got my MD degree, which was in 1982. So it's a long time. I haven't had significant blood sugar elevations as a result thereof, but I think I may have occasionally found some people who had slight elevations of blood sugar when we put them on liothyronine, that's T3. And it's worth it. T3 can make a big difference in how you feel, and it can make you less tired, improve your memory, and so on. So I find liothyronine to be of great value, as we've discussed in my videos. The small possible effect on blood sugar is worth it. Is it possible to achieve similar results by using a closed-loop hybrid system such as the MiniMed 670G, or using a combo of Dexcom G6 and a pump, and being very proactive in dosing and using the Dexcom data? And if such success can be achieved this way, then why would anyone want to subject themselves to such a restricted diet? My 16-year-old type 1 diabetic son absolutely won't even consider your diet. Well, as we've said over and over, I've never seen a well-controlled patient, at least not long-term, on any insulin pump, and for a variety of reasons. And I would suggest that you show your son type 1 grit on his computer, type 1 ONE grit, GRIT, to see what sort of blood sugars other children are getting, and how they react to the diet that they're getting, the low carbohydrate diet. It really changes their lives dramatically. And many people who have not been growing are growing. And your son probably doesn't know that elevated blood sugars impair brain development. My mother, 87, has diabetes. Her blood sugar before meals runs 14 millimoles per liter, which is about 252 milligrams per deciliter. Her blood pressure is elevated. She is losing muscle for no known reason. Well, to me, the reason seems obvious. Can it be some hormonal system or some body system not performing normally and backfiring? As a result, energy one day, no energy another day, and sleep very much, way beyond 8 hours. Well, this is what my life was like when I was having high blood sugars. I never knew what my blood sugars were because we didn't have blood sugar meters in those days. But having a blood sugar before meals of 252, and then after meals, if you're on a high carbo diet, you could go up by another 200, be 452. So it sounds like this lady needs very close blood sugar monitoring. They should read my book. She may need insulin. She certainly needs a low carbohydrate diet. Now, if she's sleepy, if she's sleepy on and off, that's probably from on and off high blood sugars. If she was sleepy all the time, I'd suspect low thyroid. My 15-year-old daughter has been following your diet since November 2018. Her blood sugars are staying in the range between 70 and 100, 90% of the time during the day. She is on the Omnipod pump and still using Humalog. Night times are difficult for us, as even when I completely suspend her basal insulin for the entire night, she still goes low. Well, I've repeatedly spoken about the study that John Galloway of Eli Lilly performed in the 1980s, around 1980, where he injected a large dose of regular insulin into a muscle and of a non-diabetic, and gave him intravenous glucose drip and to prevent hypoglycemia, and his blood sugars kept dropping for a week, and they had to keep infusing him with glucose for a week to prevent the low blood sugars from this one dose of insulin. Well, if you have an insulin pump, you're pumping insulin into one spot over and over, and it builds up. And as you develop more scar tissue at the infusion site, you're slowing down the absorption. So here you have like a shell of scar tissue around this big blob of insulin that's been accumulating there, and it's going to keep working for hours or days after you shut it off. So you turn off the basal flow overnight, but there's still a big load of insulin there in the infusion site. And that's one of the several reasons why you cannot get normal blood sugars with an insulin pump. My cardiologist put me on a new type of blood thinner, Xarelto, and my blood glucose readings are inexplicably high. Could there be a cause or corrections? Well, cause or correlation. Well, I'd suggest that you contact the medical department of the manufacturer of Xarelto and see whether whether it has any effect on blood sugar. I don't know about it. I tried to look it up. I couldn't find out anything significant about it, but I did not call the medical department. My daughter is 14 years old and has just been diagnosed as type 1. People say because she is still growing, what do you recommend? But her lunchbox. I suggest that you read my book, Diabetes Solution. To perpetuate normal growth, you need normal blood sugars. This was demonstrated by Bill Tamberlane at Yale about 40 years ago. And I see this over and over in my patients. I see kids who have stopped growing. They come in here. We put them on a low carbohydrate diet, normalize their blood sugars, and all of a sudden they start shooting up. I mean, their height shoots up. My daughter is 17, was diagnosed when she was 13. These 5 years she was on 8 to 10 insulin. I guess that's units per day, but I'm not sure. 2 months back, she suffered from dengue, that's how you pronounce it. And from there, her insulin requirement has shot up to 35 to 40 units per day. She uses Lispro Premil and takes it as a correction also many times. She also takes Lantus at night. Well, first of all, the most important thing is, did you change her diet? Since dengue involves dehydration, diarrhea, and so on, you may have changed her diet and put her on a high carbohydrate diet, and that might be what's causing the high blood sugars. Another possibility is prolonged dengue infection without symptoms. Now, I don't know if this occurs. I don't know anything about dengue. It was mentioned only briefly when I was in medical school, and certainly not with relation to blood sugars. But any infection can raise blood sugars, and it could be that there's some hidden or occult infection. There are tests that can be used to discern whether there's an infection going on, and an infectious disease specialist might know what tests to do. Blood counts, a white blood cell count, C-reactive protein, maybe a few other tests. The other possibility is merely that the high blood sugars during the dengue infection burned out her beta cells, and now she requires more insulin. And the reason she requires a fairly large dose could be because she's on a high carbohydrate diet. My wife follows your diet, but her sugars remain in the range of 200 to 350. Need your guidance to tell us what is going wrong here. Well, your wife probably has diabetes, and diabetes does not reverse just by cutting back on the carbohydrate. There are many things you have to do depending upon how severe the diabetes is. So a type 1 diabetic, as indicated in my book, has to be on a low-carb diet and has to be taking multiple shots of insulin, and at least 2 different kinds of insulin. Type 2 diabetics may be able to get away with diet, exercise, and oral agents, but just the diet alone will only work on people who are very mild, or you could call them borderline diabetics, pre-diabetics, people who have maybe an A1C of 5.4, 5.5. Those might respond to diet only, but most diabetics require medication of some kind. So I suggest you read my book and find out what tests you'll have to do. She'll certainly have to do frequent blood sugars before and after meals, etc., to find out what's going on. My doctor prescribed 100 milligrams Invokana in addition to metformin. I am concerned about side effects. Although I find it to be quite effective to lower blood sugar, what is your recommendation regarding SGLT2 inhibitors? It's very interesting. The American Diabetes Association is strongly pushing the SGLT2 inhibitors to treat type 2 diabetes. They're even recommending them as adjunctive to type 1 diabetes. There were some studies that suggest that they may reduce the incidence of heart attacks. However, they work by lowering the renal threshold for glucose, which means that you start peeing away glucose at a lower blood sugar than you normally would. So if a person would, let's say, normally start peeing away significant amounts of glucose at a blood sugar of 170, with the SGLT2 antagonist, they might start peeing it away at 140, which means more glucose going through the entire renal filtration system. And because glucose is the cause of diabetic kidney disease, I'm sort of fearful. It's just my intuition. It's not a certainty, but my gut feeling is that running a lot of glucose through the entire kidney and urinary tract system is potentially hazardous over the long term. And real long-term studies haven't been done. So I'm not recommending SGLT2 antagonists for almost all of my patients. Now, if I have one patient who's a pilot. We're right now using a variety of oral agents, including some supplements, plus the low-carb diet, so that he won't have to take insulin because he won't be able to fly over some states in the USA. If I had to give him an SGLT2 antagonist, I would discuss it with him, and he might want to do that. But for the bulk of my patients, I'm reluctant to do this. I have one patient who already had a heart attack before I saw him for the first time. He had a very high LP small a. And he discovered, before he came to see me, that an SGLT2 antagonist helped his blood sugars a lot. He was a type 1 diabetic, but insulin resistant, and things went much more smoothly when he took an SGLT2 antagonist. I left him on it because he got the best blood sugars he ever had with it. I'm not prescribing it for other patients. So that's my opinion. I could be wrong. The only way we'll find out is over a period of many years to see what new complications start appearing over the long term. My son is 2 years old and was diagnosed with type 1 at age of 13 months. I'm just wondering whether a low-carb eating plan is okay for someone this young to follow. Again, I only repeat these same questions over and over because I think it's so urgent that little kids be put on low-carbohydrate diets and not on the ADA diet because you're severely impeding brain development if you give kids high carbohydrates and high blood sugars. You're also impeding growth. My teenage son runs cross-country and needs to eat 2,500 to 3,000 calories a day. He already eats a high-protein, high-fat diet, but we struggle to get him enough calories even on a 40 carbs per meal diet. Do you have any suggestions? Well, first of all, I don't know how you know how many calories he needs. I suggest that you follow his body weight and his growth. If he's got normal blood sugars, he should be on the growth curve that he was on several years before he developed diabetes. If he has fallen off that growth curve, something is wrong, usually high blood sugars. Now, the cross-country running may not be helping his blood sugars. What I usually recommend for weight gain, if that's a problem, is more protein with whatever fat comes with the protein and more insulin until you get to a point where you're getting either no weight loss or adequate weight gain. I also recommend that when you're doing a run, you have liquid glucose with you. You have a system for blood sugar checking, let's say every 20 minutes or so. That might mean posting friends along the route, or it might mean stopping, taking a blood sugar, and then seeing how much glucose you need. And I advise my patients to try to keep their blood sugar a little on the high side. Let's say instead of 83, keep it around 90, because they know that it's going to be dropping from the running. So they, by trial and error and experience, have to work out how much glucose they should be taking by mouth and how often. To try to eat fat or protein in advance is very difficult, because the running stimulates the sympathetic nervous system, which turns off digestion. And the easiest stuff to digest is liquid glucose. So we don't try to hope that you're going to be able to convert protein and fat to energy. We don't want to stock up on carbohydrate in advance with the myth that you're going to build glycogen in the muscles, because there's a limit to the amount of glycogen you can store. So you really need liquid glucose to keep you going while you're running. Please elaborate on high cholesterol issues with 18-year-old type 1 boy. Meds are not bringing the number down. Please talk more about particle size LDL and oxidized LDL tests. Well, you can ask your doctor to order the real cardiac risk factors in blood tests, not the fictitious ones. A sampling of the real ones include total HDL, which is negative risk factor, fibrinogen, homocysteine, C-reactive protein, triglyceride, non-fasting triglyceride, and there are a number of other known cardiac risk factors. I should have included also lipoprotein small a. There are many doctors who are in the dark ages with regard to cholesterol and heart disease, dietary fats and heart disease, and I'm sure many of my videos have discussed the bribery that actually went into the cholesterol and fat myth that was popular in the 1950s, 60s, 70s, and 80s, and still perpetuates to some extent today, where manufacturers of sweet foods literally paid off research investigators, non-profit organizations, medical societies, and universities. And this is all in the scientific literature. Articles on this were published in the Journal of the American Medical Association and in other journals. We're all familiar with the complications from frequent high blood sugars, but besides the immediate symptoms, are there long-term medical consequences from frequent low blood sugars? Yes, there are, and especially if there are convulsions. It's been shown in some occasional studies that after a convulsion, you get micro hemorrhages in the brain, and you have enough convulsions from low blood sugars, you'll have more micro hemorrhages. So you can do some damage from low blood sugars. There's been, I believe, 2 studies that showed a J point in mortality in large populations, where one was done, I think, in Korea, and I forgot where the other study was done. But what they found, both studies found the same J point, that is, at around 83 milligrams per deciliter, was when you were looking at average blood sugar based on A1C, and one study was based on fasting blood sugar. Around 83 was the lowest mortality. And as blood sugar went above 83 and below 83, there was greater mortality. Now, this does not apply to children. This was done on adults. Children tend to have blood sugars in the 60s and 70s normally. Type 1 for 1 year. I take 13 units of Tresiba in the morning and 3 units of bolus for meals. I exercise after dinner for 30 minutes on a treadmill. I eat dinner at around 6 p.m. every night. I find that if I go to bed with a blood sugar of under 150, I always wake up in hypo. What is causing this? Again, I suggest that you read my book, Diabetes Solution. You're taking your Tresiba in the morning, and you need Tresiba at night to cover the overnight situation. The manufacturer of Tresiba and many physicians claim that it lasts 24 hours. That's a myth. The manufacturers of all of the longer-acting insulins, of which there are not many, claim effectiveness for 24 hours. It's because the studies that they did not use basal doses. Basal means enough insulin to just cover the fasting state. And what they do in their studies to create phony data is they'll give you 1.5 times the basal dose or double the basal dose, so that there'll be a big amount of insulin sitting in one spot under your skin, and it takes a whole day for you to absorb that. But it's forcing you to eat all day long until the tail end. So that's not basal insulin. That's the old ADA ball game, where they would give 1 shot of protamine zinc, a long-acting insulin, once a day, and force the patient to eat all day long to cover the insulin. That's what was done with the studies that these manufacturers submitted to the FDA. They made it look like it lasted for 24 hours by giving more insulin than was needed. What you have to do is split your insulin doses. Now, many people can get away with 1 dose of Tresiba on arising in the morning and 1 dose at bedtime. But many of us, especially full type 1s who make no insulin, many of us have to take it at bedtime and then a second dose at maybe 4 o'clock in the morning, before literally setting an alarm to wake you up. I fortunately or unfortunately have to pee sometime in the middle of the night, so I'll get up to pee and I'll take my second dose of Tresiba at that time. And most of my type 1 diabetics are getting a second dose of Tresiba. They're getting it at bedtime, and a second one maybe 6 hours later. What are your thoughts on the carnivore diet? In other words, all your food comes from the animal kingdom. Well, I don't know that that is necessary or even sufficient. I have a carnivore dog. He's about this big, but he eats little bits of weeds and flowers. So he's also getting some vegetation in addition to his animal meat. I think that humans evolved on mostly uh, animal flesh. Those that lived near the coast probably ate a lot of fish. Those that lived inland ate animals. A recent study done about 15 years ago in Africa at people who still lived in the jungle found that they were eating turtles, insects, and small animals, and nothing else. I suspect that there may be some value to nutrients that you get from plants. So when I worked out a low carbohydrate diet for myself, I included vegetables, a little bit of vegetables for each meal. That's where the 6, 12, and 12 grams of carbohydrate per meal, 6 for breakfast, 12 for lunch, 12 for dinner. It might be more than you need, but it's a speculation that we need nutrients over and above what you get from strictly carnivorous diet. And that's just speculation. I imagine that people can survive with a strictly carnivorous diet. What do you think about the J-shaped mortality curve according to hemoglobin A1C? Well, I spoke about that already, so we're not going to talk about it again. I am seeing studies that say carbohydrates should be 50 to 55% of calories for best health and longevity. Any thoughts? Those are not studies. Those are opinions. I'm willing to bet that you cannot find a single study that cites any value to a high carbohydrate diet. You'll see many claims. The ADA will make claims, but even the ADA is backtracking and now making vague comments like diets should be custom tailored to the individual and should take into account individual preferences. And they're afraid to say that diabetics should be on low carbohydrate diets because they're still getting huge amounts of advertising money from manufacturers of sweet foods. Despite only having prediabetes diagnosed last year, I think I have diabetic neuropathy in my feet and lower legs, present for 8 years. Any recommendations to reverse or prevent progression? Well, first of all, what most people call prediabetes, I would call mild diabetes. Blood sugar elevations cause damage to the nervous system, and because nerves allow the influx of glucose without the help of insulin, even if you're not making enough insulin, you get loads of glucose in the nerves. So nerves are usually injured early in the time frame of diabetes, even when it's very mild. And I've seen many patients who were newly diagnosed but already had complications of diabetes. And the scientific literature for years was indicating perplexity over why is it that so many diabetics have diabetic complications before they're diagnosed. It's because the diagnosis wasn't made early enough. And what do you do to reverse neuropathies? Well, fortunately, most neuropathies are reversible with normal blood sugars. And depending upon how long they've been present, they might be rapidly reversible or slowly reversible. For example, I've seen people who speak of numbness or pain in their feet getting recovery, partial recovery, within a month or two of normal blood sugars. And then it gradually recovers further over a period of years. My gastroparesis took at least 13 years to normalize. But it had been present maybe for 25 years before that. Maybe it was 35 years. So this thing is reversible. I'm trying to think of other examples. People with erectile dysfunction, if it was a recent onset, if they're diabetic, we find that within a few months the erectile dysfunction reverses, but not totally. It takes years for it to totally reverse. Why are diabetics supposed to get flu shots? What evidence is there to support this? Diabetics are more susceptible to infections, especially bacterial infections, because bacteria love glucose, and they will proliferate if there's more glucose in the bloodstream or in tissues. Viruses proliferate when the immune system is impaired, and the immune system is also impaired in diabetes. Diabetics are probably more susceptible to the flu, and probably the instructions to get flu shots are more applicable to diabetics than to the general population. When I give flu shots, I use the quadrivalent vaccine, which protects against 4 strains of influenza rather than the less expensive trivalent vaccine. Can the diabetes solution diet minimize the effects of insulin autoantibodies? Let me think for a moment. Probably can, in an indirect way. If you're, let's say you're a type 2 diabetic still making insulin, the insulin autoantibodies, there are actually 2. One is anti-human insulin antibody, which would attack beta cells as insulin appears on their surface. So if you're on a low-carb diet and therefore making less insulin, you're going to expose fewer beta cells to the antibodies that are going to attack the insulin. GADA is a protein that forms on the surface of beta cells it actually is a protein in the little vesicles that enclose insulin granules as they're made in beta cells and are transported to the surface of the beta cell. When the vesicle with the granule inside it gets to the surface, it merges, the vesicle merges with the cell surface, and the GADA is briefly exposed to the bloodstream. So antibodies can get to GADA and attack it only when you're secreting insulin. If you stop secreting insulin or you minimize the secretion of insulin, there's less GADA exposed to these antibodies. So yes, if you're on a low carbohydrate diet, you're going to make less insulin and get less beta cell destruction. When I experience hypoglycemia and take in sugar or carbs to increase my blood glucose, does it mean the ketosis I had established with the diet has been altered and I need to start from square one again? This is a statement of likely sheer ignorance. A person is trying this ketotic or ketone diet, which is spreading around the country inappropriately, and is thinking that somehow by having ketones in his blood sugar is going to get lower. This is all nonsense. I I suggest that the only reason for even testing your blood or your urine for ketones is if you don't have a scale and you're trying to lose weight and you want to demonstrate that you're burning fat, you could test your urine for ketones. You could also test your blood, but that's more expensive. So there's no reason to follow these ketotic diets, and there's potential harm depending upon how they're performed. So I suggest you just call it quits. Next question. When I take in protein and gluconeogenesis is activated, my blood sugar rises. Well, you're not taking insulin to prevent the blood sugar rise. But since it is not carb counting, it is difficult to estimate how much insulin I need. Well, carb counting is another myth that doesn't work. The ADA and perhaps some other organizations claim that the only thing that raises blood sugar is carbohydrate, and yet they advocate high carbohydrate diets. So neither makes sense. All foods can affect blood sugar, and for a type 1 diabetic, you can even eat a handful of pebbles if you feel like it, and it will raise your blood sugar. This is explained in my book, Diabetes Solution. So trying to eat different foods at different meals and pretend that you know how much insulin to give is a myth. The ADA is perpetuating a myth that you could eat whatever you want as long as you take the right amount of insulin. Well, you'll never know the right amount of insulin because until you experiment with that particular meal, see how much insulin to inject, how long before the meal, or if you have gastroparesis, how long after the meal. You'll never get the number right. And that's one of the reasons why people on insulin pumps don't have normal blood sugars. They're told that all they have to do is inject the right dose according to the pump maker's formula, which never works, and they never get normal blood sugars. Well, I could retract that partially. At the very beginning, when you're first diabetic and making your own insulin, if you have an insulin pump, your own insulin can take over and help you. But once you've destroyed all your beta cells, the pumps go haywire. Have you been able to track your or other type 1 patients' C-peptide numbers and see any improvements after a period of success in keeping consistent ketosis? Again, another myth. Now, doctors are still checking C-peptide levels in patients periodically. I know there's a large diabetes clinic in Boston that checks C-peptide levels every year in a group of patients that they're studying, and they don't check blood sugar at the same time. Now, let's take a normal non-diabetic. He's making insulin. You can estimate the amount of insulin he's making right now by measuring his serum C-peptide level. But if you feed him some glucose and his blood sugar goes up, he's going to make more insulin. So the higher his blood sugar, the more insulin he's going to make. On the other hand, if you were to inject a little insulin into him and make him hypoglycemic, he'll turn off his C-peptide. So to measure C-peptide level in a patient without simultaneously having their blood sugar you have no information. This practice of measuring C-peptide without measuring blood sugar is a waste of time. And certainly, as I've said previously, um, uh, uh, thinking that ketosis is somehow going to affect C-peptide levels is a myth. Thanks for listening to our June 2019 teleseminar. Our next teleseminar will be July 31st, a Wednesday. Please join me then. Thank you.